Hello, everybody, and welcome to the World Health Summit and to our panel on COVID-19, driving effectiveness and efficiency in healthcare. Efficiency and effectiveness are both critical questions to improve healthcare, in particular as we have seen it in the current COVID-19 pandemic. By improving efficiency, we get to smoother and quicker processes, saving valuable resources. By improving effectiveness, we focus on measures that have impact. Being efficient is not valuable if the measure does not have impact. Effectiveness may come at a high price, as we have seen in lockdown scenarios. As we have seen, this is most important in critical situations like the pandemic, where we all experience shortages in our medical resources. I'm very happy that we have this excellent panel to allow us to explore that topic from diverse views. I have the honor now to introduce Professor Alina Büchs, Professor of Ethics in Medicine and Health Technologies at TU Munich School of Medicine. She has worked on topics like solidarity and responsibility in the corona crisis and big data and health. Her research focuses on ethics of medical innovation and health technologies, research ethics, questions of solidarity and justice in contexts such as public health and healthcare provision. She has been elected chairperson on the German Ethics Council in May 2020. Welcome. Francesca Colombo, the head of the Health Division at the Organization for Economic Cooperation and Development, OECD. She has over 20 years of experience leading international activities on health and health systems. She's an international expert on health care issues for elderly populations and led projects on quality of healthcare policies, health financing, and the impact of private health insurance on health systems and health workforce. Professor Ulrich he serves as the Director of Experimental Neurology at the Charité Universitätsmedizin Berlin. His research is focused on stroke, cerebral blood flow regulation, and brain imaging. He is also the founding director of the Quest Center for Transforming Biomedical Research at the Berlin Institute of Health. Quest aims at increasing the value and impact of biomedical research by maximizing quality, reproducibility, and validity of research. Dr. Ricardo Baptista Leite is a medical doctor as well as a member of the Portuguese Parliament, Health and Foreign Affairs Committees, and a national spokesperson for health of the Democratic Party in Portugal. He is the president of Unite Parliamentarians Network to End HIV, AIDS, viral hepatitis, and other infectious diseases as global health threats by 2030. He is also head of public health at Católica University in Portugal. Professor Michael Neumeier is a laboratory physician and clinical chemist. He holds the chair of clinical chemistry at the Mannheim Medical Faculty of Heidelberg University and also heads the Institute of Clinical Chemistry at the Mannheim University Medical Center. Professor Neumeier's scientific focus is on oncology, molecular immunology, and quality assurance of complex diagnostic procedures in laboratory medicine and the biomolecular quality in clinical and archived biobank samples. He runs CovLab, the first comprehensive COVID-19 mobile laboratory in Germany, and develops new high-throughput testing strategies. Bart de Witte is the founder of AI Hippo, the first global nonprofit to focus on open-sourced medical AI, as well as the founder of the D-Health Academy in Berlin. The D-Health Academy aims to cultivate a digital culture in the health field by training healthcare professionals in groundbreaking technology. He is also a faculty member at Futuro Institute, a German research institution developing transformative data-driven medical technologies. Previously, he was the director of digital health for IBM. So welcome all, and thank you very much for joining this panel. And may I ask now the members of the panel for giving us their introduction statement on our topic of improving effectiveness and efficiency in healthcare in light of the pandemic. Professor Neumeier. Oh, you're on mute.
Good morning. Hello, everybody, and to the colleagues from the panel and all the audience. Thank you for having me. I would say that diagnostics is always at the leading edge of a successful clinical decision making. So we use diagnostics usually when an individual with a health condition presents with a phenotype of a disease. But now in COVID, in a pandemic like this one here, we need breadth-ways strategies for the earliest possible virus detection. That means we are to apply these strategies on an asymptomatic, seemingly healthy population on a large scale. So this is a completely different diagnostic situation. So the requirements regarding our test technologies will shift, and so does the need to adjust our diagnostic procedures. Only then will high throughput testing achieve the goal of proper monitoring the situation of the disease. But it's not only the technical or analytical process, we also need to communicate the proper interpretation of the test results if they should help to improve a correct identification of the infected people, the tracing, and also any containment measures. That means that next to the medical specialists, we need to educate the people to understand the test results. They also need to understand the correct test interpretation, and that the test interpretation will depend on the test which has been used and in which context it has been used. Currently, we do not have all these challenges solved, and we do not meet all the criteria for this process. So in our opinion, one cornerstone would be to develop comprehensive mobile laboratory testing strategies that, together with adjusted interpretation and IT infrastructures, will provide a rapid turnaround of reliable test results and thus deliver healthcare under aspects of effectiveness and efficiency. Thank you.
Thank you very much. So, Mr. De Witte.
Yes, good morning, everyone. Also in Berlin, but physically not present. So when we talk about effectiveness and efficiency, it is at this stage for me difficult to make any comfortable conclusions and predictions, as we are still in the thick of the battle against COVID-19. And as you know, when you are in the thick of a battle, you are surrounded by a fog of war. And within this fog, it is difficult to navigate. One needs to be able to become agile and nimble, where agility means that one needs to be able to act quickly. It's related to trusted communication, where nimble focuses on our collective intelligence that allows us to act intelligence and learn quickly. And as our world got digitized and is connected, our navigation system has been based on data and models that allow us to predict and learn together. And data is more or less the bloodstream of this collaboration. So it was for me wonderful to see and witness when I started an open source community that within a number of 8 weeks, we managed to create a global community of 80,000 people that created in 42 countries. And we produced over 25 million goods based on open source designs. Even the FDA and the NIH cleared some of these designs for emergency use authorization and broke down the walls that led to these innovations to be applied. So everyone within the community, and that was the most learningful, had a shared purpose. And the collaboration was based on altruism and empathy. And although some people within the community joined there for the benefit of themselves and tried to patent some of the open source designs, 99% of the community shared their designs under a common license. So it is, for me, very crucial that we need to further open up data and start to further open collaborate, and that we need to break down the walls that avoided people to have access to data and didn't lead to open collaboration. So for me and my organization, our joint enemy after COVID, when the fog has cleared, perhaps is to destroy inequalities. And that can only be done if we break down the walls that lead to open access to knowledge and information.
Thank you. Ms. Colombo, what's your take on this?
Sure, thank you, Dagmar. And the question you pose is huge. I mean, efficiency and effectiveness are such vast topic. So maybe a few considerations with no pretension of really exhaust this incredibly vast topic. I think the first thing is a bit of being humbled. Health systems in the countries that were the most advanced have been very much affected by the crisis in ways that were completely unexpected. So we thought that at the beginning we had very resilient, very strong health systems. And the reality is that what we have seen is that we do not have systems which are as strong and resilient as one would wish and want. And clearly this called for major rethinking, both, of course, how to handle the next upcoming or already occurring surge in cases and the new wave of infections that we see in Europe. But I think also projecting into the future, how can we have health systems which are much more resilient and efficient? So two considerations. It's quite clear that there is a need to invest in smarter way in health systems. Doing business as usual as was done in the past is not enough. And secondly is that you need, while to invest more in health system in that smart way, you also need to tackle the investment and the spending that deliver no benefits, and both need to come at the same time. So just some examples. In investing more in smarter way, clearly digital technologies and digitalizations is fundamental, as was mentioned already by the previous speaker. But with all the efforts, health system remained washed with data, but very much information poor. And I think there is an opportunity in the current crisis, which has really provided the impetus and accelerations for digitalizations, artificial intelligence, generation of more timely data and so forth. But the solution is not by digitalizing systems that were set up before the digital era. We need to address more fundamentally the strategic overhaul of health system in the context of digitalization of the economy, addressing more governance, particularly data governance issues, and adding to the capacity of the system, not just in terms of IT, hardware and software, but also in terms of skills of professionals, for example. So that's where the investing more, investing smarter. One example is digitalization. There are others as well. The other issue is that we need to continue to tackle spending that deliver no outcomes for patients. We have done years ago major reports on wasteful spending in health system, mentioning how about 20% of health spending actually delivers no benefits for patients. And that's something that in the current crisis is clearly not acceptable. So how can we address, that large spending, including hospital spending, that is goes into more correcting errors that could have been avoided with more, focusing adoption of the clinical guidelines, or with better use of data as well to avoid those medical errors. How can we make sure that the flows of data goes to decision making in a way that helps addressing those inefficiency? How can we reduce inappropriate care? Care which is delivered without following the medical guidelines, for example. All these issues are becoming ever more important. So, twin message: we must invest more in health system, and there will be probably much more discussion about the need to invest more in health system in smart way. At the same time, we must continue to tackle that activities and spending that deliver no benefits for patients' outcomes. And I'll stop it there.
Thank you very much. I think we will come to that, of course, in a lot more detail. Professor Bernardin.
Yeah, good morning. Normally I would have taken my bike to the conference venue. It's a bit different now. So I think we have already seen tremendous response by to the pandemic by the research enterprise. And I just checked as of this morning, more than 2,600 ongoing or completed clinical COVID studies are registered at clinicaltrials.gov. And I also just checked more than 63,000 COVID publications can be found on PubMed now. And they are practically all open access. And I think the publication of results has tremendously accelerated, in particular by preprints. And as we have just heard from Bart de Witte, there's lots of open science collaboration. So we see great progress in treatment diagnosis. And I also think that vaccine development seems to be on track. So all this obviously is positive, at least in principle. However, I believe that the pandemic acts as a kind of a magnifying glass and an accelerator for already existing problems in biomedicine that we had before COVID struck. And these are mainly in study design, execution, and publication, as well in the proper vetting of study results. What we see now has been called research exceptionalism and even COVIDization of research. And so I think indeed there is a tension between speed and robustness and quality. And under pandemic conditions, the motto sometimes seems to be bad data is better than no data. But just if you think about the development of vaccines, this is not a good idea. And I think we need to be very careful and not sacrifice quality for speed. Thanks.
Thank you very much. Yeah, also the tension, quality and speed, obviously is something we come back. And maybe also that takes us right to Professor Brooks. What do you think about it, also from the ethical side?
Yes, thank you very much. Thanks for having me. Hello to everyone. Just a very quick note that I'm speaking here on a personal capacity and not on behalf of the German Ethics Council, which gives me a little more freedom. My few remarks will follow on beautifully from what Ulrich just said, because there is I want to say two things, and the first thing follows on directly. There is a very important case to be made for heightened efficiency in a pandemic. And I think what we've seen across the world and what we've seen, those of us who have the job to monitor studies and science have seen that there has been incredible effort to become more efficient. And it was a sight to behold, and it still is. It's very impressive. At the same time, it's very important that we don't overdo it. So we need to find a balance here, and not just because the quality of results might be compromised. That, of course, is one of the major reasons. There is also a second reason, and that Ulrich Diernagel has already alluded to. Trust in the findings could be destroyed. And trust, not just in medicines, but in particular also in preventative measures such as vaccines, is highly important. We are in a global crisis. People are tired. People are overburdened. All of us have had 6 months that we've never had before like this, at least over the last 50 years. There is a lot of fake news around there, and we need to keep the trust in the scientific enterprise as strong as possible. And in particular with things like vaccines, where we know that they are already a contentious element of medicine, and there is a lot of false information out there and a lot of false beliefs, it's very important that we strike this balance. And I'm very happy to say that in terms of the vaccine development that I have seen, it has gone very quickly, incredibly quickly, but not because steps were, how do you say, because we left something out, but because we just got so much quicker at doing things and did them in parallel, which is incredibly costly, but doesn't compromise on quality. And I think that's the first thing I want to say. And just very briefly, because I know that that is something that we will come back to, I want to make a quick point about data protection. Again, we have a great ethical tension here. On the one hand, data protection is there because it protects not the data as such, but the interests of the people behind the data. So there are civil liberties, important civil rights that are protected, the right to privacy and the right to autonomy, in this case, to data sovereignty, as we call it. But of course, in a crisis, we have other civil rights that are at least equally important, the right to life, the right to health, and so on. And we have also, by doing what we do in the crisis, in the COVID pandemic, we have compromised these many personal rights very intensely, for example, by measures of lockdown. So there is a complex question to be asked, how we can balance this and how we can make sure that we are responsible in our data use and that we still respect the personal rights behind this as much as possible, while at the same time not making data protection sort of the paramount civil liberty, because it isn't. So we need to find a very good balance. And to my mind, that is one of the greatest challenges that we face currently in research and science. So I'll leave it here. Looking forward to the discussion. Thank you very much.
Thank you very much. Yeah, and questions of trust and I mean also the ethical points also lead us to politics. So, Mr. Leiter, what is your point, your view on that?
Thank you, Dagmar, and good morning to everyone. I wish we were in Berlin, but it is not the case, so I have to stay in sunny Portugal. It's not so bad on my side. But it would be great to be with you so we could discuss the importance of the effectiveness and efficiency in healthcare, especially in this context of COVID-19. And we've heard multiple examples coming more from the research and scientific communities, which I agree have had some positive outcomes, have shown the capacity to bring coalitions together to make sure that we are able to accelerate the development that is so much needed. On the policy side, however, being a physician trained in infectious diseases, elected into parliament as a member of parliament, and also as the head of Unite, the global network of parliamentarians to end infectious diseases, I am very concerned at the moment we are living. We see that most governments have used health systems, instead of being the last line of defense, as being the first line of defense. We have been reacting instead of preventing new cases. We need urgently to understand that policy needs to be focused at lowering the incidence of new COVID cases, without which, no matter how strong your health system is, it will collapse. And this is something that I think is not very clear. At the beginning, when most countries decided to lock down, it was for two reasons. One was to protect our citizens, to save lives, to crush the curve, as we said at the time. We stopped using that language, but it's so important. And the second thing was to gain time, because we were facing an unknown threat, so we could prepare ourselves for the time to come. The thing is, that preparation in most settings was not done. And once again, we are facing the current second wave in many countries, especially here in Europe, using exactly the same methodologies and tools that we used 6 months ago. From a policy perspective, we need to change, because it is not enough to say that we want our economy to keep running. We need to make sure that we do everything in our power so that can become a reality. Health and economy are two sides of the same coin, and we need to address them as such. Someone was mentioning the importance of data. Data is a prerequisite for the health transformation that is needed. The fragility of data has become very clear throughout this pandemic. So I would say that COVID-19 is a mirror image of what is wrong and needs to be fixed in our health systems. Our health systems have been designed to react to disease instead of promoting health, instead of preventing disease. We should be focused on lowering the burden of disease, of enabling the wellness of our people. Sadly, that is not the case. And so, as a first remark in this idea of how we should be driving effectiveness and efficiency moving forward in our health systems, I would say that we need to shift from the disease systems that incentivize disease, that managers are somehow pushed towards having more and more sick people, to making sure that we have systems that are capable of promoting health. And data is the prerequisite, as we can discuss, for the health models and health systems and new financing models that we need for this kind of philosophical transformation within health systems, as we also need a major transformation from a policy side, even on our economic models, understanding that GDP is not enough for us to measure growth. We need to make sure that that growth trickles down to the people, without which we will see growing inequalities, which has a tremendous impact on health, which with the upcoming years following COVID-19, with the economic and social crisis that we are facing, seeing so many countries dropping the SDGs as a priority, we need to make sure that we fight for those that are in the most vulnerable situations right now.
Thank you so much. And thanks a lot for your introductory statement. I think that shows us that really a holistic view is necessary to change systems, right? And I think that a lot of faculties have to contribute. So maybe let's start with some more detailed questions then. First, Professor Neumeier, you are driving diagnostic innovation. You mentioned the mobile lab, yeah, and I mean, more agility and flexibility is obviously something that seems to be of high interest in a situation like this, to make resources available directly to places where needed. Yeah. So what is your experience with mobile test designs, and where do you see the shortcomings in delivery outside of a hospital or emergency scenario?
Yeah, thank you very much for that question. Certainly, we need to get better penetration in the expanse where we look for the disease in order to break the cycle of the virus, obviously. As has been said by Alena Büchs, it's very important to have people keeping trust in what the results are. That's very important. And also it has been just said that data are at the have a very important aspect in this, but the data also, the data that you use to calculate, to interpret, can only be as good as the results that are the basis of the data, obviously. So what we decided at some point that we needed to take a more breadth-based way of penetration on the testing, and so we designed this mobile laboratory, which we call CovLab, which is actually an 18-wheeler, 40-ton truck, which allows us to take the sampling, allows us to do the molecular analysis. On site, has an uplink to the university hospital where we have the medical professionals doing the findings and report back the results within a couple of hours to the participants and also to the health authorities that need the data for containment purposes. So this is basically the setup, and obviously it's a first measure as we see it. It certainly helps for some specific in some specific situations. It will not help, obviously, for everything, but we learned a lot of things about bottlenecks in the procedures that prevent us to do breath-ways testing at the moment, which is basically, for example, taking the sampling speed. So a professional, experienced, skilled health professional that takes samples can only take 30 samples an hour. This is something that we see all the time. He has to be gentle and he has to be thorough and efficient. It's very difficult to combine sometimes, and people don't like this type of sample taking. So with the healthy people, it's very difficult to convince them that they should get tested in a way. So you cannot force people to get tested, let's say, for example, in authorities, in schools, and so on and so on. So you can imagine with this type of throughput, you the number of staff you need to do a large-scale testing, basically. And then there's, of course, other things that can be discussed. You can say you can bring the people to the laboratory, which is usually not possible. Of course, you cannot shift people back and forth in large crowds to laboratories. You can have mobile stations that, that's what we tried. We have mobile stations that take the samples and then you can bring those to the laboratories. But we decided on just basically combining this because we think it's the most efficient way to do it. And for that, you also need to look at the whole entire process, the whole workflow of the procedure, from taking the sample through the analysis all the way down to the reporting, communication of the data. So that all has to fit together to make it a sound and efficient way and procedure. And so there's, as Bart de Witte was saying as well, so it's amazing to see how many different disciplines, groups, and stakeholders have started to team up to get these types of procedures going. And we think that basically there are a number of important aspects beyond COVID, which is mobile testing altogether in a mobile society. So we have learned so far that with our capacity of, let's say, 500 tests per day that we can do, which is quite a sizable number if you think about it, on molecular tests with same day reporting within hours, that is something that is important for containment. And we have not explored, of course, the implications of this gain of speed. So far, we're in the process of doing this, and we team up with other colleagues to compare procedures in order to be able to improve on our approach, and also maybe help making suggestions to improve diagnostics in the pandemic altogether. Thank you.
Thank you. So a mobile lab, yeah, I think it's this form of agility. And Ms. Colombo, you also mentioned smart investing. Yeah, it's maybe a bit more adjectives, you know, more from the industry as and then from medicine. So what do you think? Yeah, does the pandemic affect our models of care delivery? Should we have less hospital beds and more mobile and digital access to healthcare? To, for example, in contagious diseases, yeah, like we see it in COVID-19, which protect patients and hospital staff. So in terms of smart investing, do you think there are ways to be considered?
Yes, there are huge ways, as a very short answer to the question. It's also a complex question. I mean, quite clearly, health systems have been incredibly rigid compared to other sectors of the economy in their way of adjusting the models of care. You know, if you think even about the health workforce, it's incredibly rigid. Tasks are very much predefined. Skills are, you know, set up. What can be done or not can be done by different health professionals, nurses versus doctors, and so forth. It's incredibly regulated, obviously for reasons linked to quality. But the system as a whole, it's quite static and it's quite rigid. So having that agility that was mentioned is quite fundamental, not just because now there is a need for the pandemic, but also because there are transformations in the care needs of populations which have been slowly happening, you know, the aging, the changing in chronic conditions and so forth. So the overarching issue is that, yes, we must have a much more agile health system. And so that means things like obviously mobile laboratory capacities, but, you know, mobile also other type of service delivery to reach underserved population, for example. The pandemic has accelerated very much telemedicine in a way which were unthinkable before the crisis. It has really accelerated, provided payments arrangements for telemedicine that did not exist before. It has triggered, the delivery of new guidelines, new regulations, new platform, mobile online platform, new services, even new legislations to make it possible. So that has been one level in which there's been a transformation in this service delivery. And obviously this has been underpinned also by high political encouragement. Now, you mentioned also hospital, and that's a little bit more tricky because clearly we have seen across countries, across OECD countries, for example, that when you look not just at hospital beds, but at ICU beds, so the critical care capacity, that varies by a factor up to 10 across different countries. So huge differences in the starting point. And quite clearly, if you have very little capacity, it's become very difficult to manage a very sudden surge in demand. So there is definitely a need to have a level of capacity to start with. But even more important is not just having the beds. If you don't have the workforce and the right workforce that can equip and is skilled to address critical care needs, then you do have a problem. If you don't make efforts to reduce the likelihood that people get into a hospital in the first place, then you do have a problem. You keep on just, reacting again, responding to a crisis or a needs that arise, rather than taking the things much more upfront in reducing the likelihood that people might need care, that people might be hospitalized and so forth. And so this goes back to what Ricardo was saying of the critical importance of investing in risk factors that underpin the health of populations. And it seems obvious, but it's something where we have collectively failed. Keep on saying only 3% of total health spending is devoted to prevention and managing of those risk factors. So that must be addressed. And lastly, we clearly need to have more agile solution for managing any surge in capacity. In terms of workforce, how about thinking about having an army of health professionals that perhaps is not working on a daily basis, but that can be mobilized in time of crisis, a little bit like the defense industry does. There is an army of potential people that can be mobilized if there is a war. Well, how about an army of health professionals or even people that are critical, which are trained with some of the basics, which can be mobilized in time of crisis, and also ability to rapidly surge the critical care capacity in agile way. So quite a lot of things, but clearly rethinking the structure, the agility, the way we are able to surge capacity, the investments much more upfront, much more in preventing rather than reacting. I think those are some of the directions that needs to be followed.
So obviously a lot of topics that we have, and I think most of them or a lot of them also allocate to really digitalization, or I think it would be a major part in agility, in if we talked about telemedicine and allocation of resources, everything is only imaginable with driving digitalization. So Mr. De Witte, you're a big advocate for driving digitalization and democratizing artificial intelligence in healthcare to provide access to data for improving healthcare in a broad range, and reduce inequalities. The pandemic has also given obviously a huge push in this direction, because as we see, we can reach high populations only with the use of it. So what do you think? What are the next steps here?
Yeah, I think this is a very complex question as well, but thank you for asking that. And as you notice, I'm not going to talk about teleconsultations. I think the first paper that mentioned teleconsultations is already 80 years old. I'm really grateful that we now adopted it. But what we are now seeing is these fast way of collaboration which is also nothing new, but it's just factor X faster. And I think we always have to remind ourselves that everything what we accomplished and everything what advanced our society and every endeavor relies on the prior work and published knowledge of others. Like open science is about extending the principles of openness to the whole research cycle. And I'm mentoring some startups, and develop apps and digital tools which also on the work of others, because they are using for 60% open source libraries. In fact, the whole internet would not exist if they would not be open source, because it was based on Linux and HTTP and TCP IP protocol. So being open is that what connects. And unlike information, I think knowledge is a human characteristic that in the country that information, that there can be information that nobody knows, but in healthcare, I think that there can't be life-saving information that no one knows. I think this needs to be open. So then when we think about the impact of artificial intelligence and data, because data itself is information, but it's the machine learning that will create the intelligence, to start thinking how we can create that open mindset into AI or the application of these tools. Means that perhaps out of my perspective, we need to create what I call digital commons. And I think these digital commons will be pivotal for innovation and creativity, but also it will be very crucial to destroy information asymmetries. And as the economist Nobel Prize laureate Joseph Stiglitz advocated, that information asymmetries always lead to inequalities. So as Francesca said during the opening statement, we need to globally, I think, align on data. And from my point of view, I think if we equal data to capital, the data economy that we are building up will pave for me a way for a new stage of capitalism, which outlines we partly can see. And I think it will be the capitalization of life without limits. So there will be no part of human life, no layer of experience that will be extractable for economical value. Human life will be there for mining without reserve. And this process of capitalization will be perhaps a foundation of a very unequal social, new social arrangement. So we really need to perhaps sit together as a global community after COVID and rethink what solution we are building with the digitalization. Is the solution destroying inequalities? Because you want to destroy inequalities, knowledge needs to stay open. As soon as we are putting a price to knowledge, we will serve the existing inequalities, and we will not grab the opportunity that normally technology does, which always further democratizes access.
Thank you. Yeah, in terms of digitalization, Professor Neuber, I'd like to come back to you also, because obviously also the lab data sets that you are generating have, on the one hand side, allow a statement regarding COVID-19, but could those test results with additional data, for example, help physicians in a different way in their clinical decision-making, or even the assessment of patients' prognosis? And would availability of those data have a really impact how healthcare can be delivered? Maybe you can give us examples or your thoughts on that question.
Yeah, well, certainly what we test at the moment is we try to detect a virus, but everybody can see from studies that are coming up all over the world in very large numbers now, showing that there is a lot of maybe chronic consequences to the health of people that have been infected with COVID-19 or had with the coronavirus. And so actually maybe generating pre-existing conditions down the lifetime of these, over the lifespan of these people. And you are certainly aware that many of those studies now suggest that we have to look at the corona infection as an infection, as an endotheliitis, which means an inflammation of the inner wall of the vessels, which fits very much data that we had found in the laboratory in routine diagnostic settings like thrombosis and these types of things, and hemostasiological disturbances in these patients. Also, there's enough evidence now suggesting that there is immunological differences between reactions of the immune system towards COVID as compared to, let's say, other infectious diseases like influenza. So there are obviously significant differences that we start to learn now, but all the data that seem to indicate that using machine learning algorithms and large and big data mining, we can find a number of biomarkers that indeed are capable of suggesting prognostic or have prognostic quality, suggest maybe a clinical course for a certain patient at a given time during disease when he starts to develop symptoms. And so the idea is, of course, that everybody has, and people are embarking on these types of studies now to find out, can we identify people early on that will maybe have a more difficult course of the disease and may suffer greater damage during the infection. So this is certainly something that has to complement the mere detection of the virus and in identifying the people that are infected. There could be, so this is, let's say, one thing that is from the COVID arena, but if you go outside the COVID arena, of course, there you can see that there may be a number of very interesting possibilities and options down in the future where we could, for example, have clinical studies using these type of mobile systems, so we can follow patients that are in a pandemic or in other health conditions, and this way maybe being helpful to a better effectiveness and efficiency of the healthcare system. And given the availability and the respective collaboration efforts within this medical arena, this mobile platform could do this. And these studies or maybe these activities for mobile testing in a world of modern medicine that becomes more and more an ambulatory activity. If you think about that, many diseases today can be diagnosed at a much earlier state where you only basically have a health condition. There's some biomarker disturbances that hint to some not yet clinically overt disease, which can then be used for preventive measures in a totally different type of medicine than what we are being used to practice in our curative medicine. So such applications using mobile systems may include, for example, the collection of epidemiological data for various health conditions, or conveying medical information and education programs on specific health issues for the citizens as part of such a prevention-driven and oriented and predictive healthcare. So I think there's some far-reaching concepts that can be developed, and I think COVID has taught us that we have to rethink our well-worn pathways and paths that we are used to go and to tread, basically, and we can maybe adopt this to other scenarios as well. And this may be something that at least we really would like to look at in the future. I would have one more comment, which does not relate directly to the question that you just asked, Dagmar, but you have to think about how reliable all these testing efforts are. And at the moment, we are talking about antigen testing a lot. And antigen testing, we know it's not 100% specific, and it's not, by far, it's not 100% sensitive. And many of the data and things and numbers that you are given if you address these types of questions on how reliable testing is, you will see that the data really don't mean anything in a normal screening situation. But for example, if you look at a test that has a 99% specificity, means if you test 100 healthy people, you will get one result which is positive, where the test is positive. So it's a false positive in a healthy population. Now, if you have your disease being 1 in 1,000 is affected, then you have one person that gets sick in a group of 1,000 people that are healthy. And you take a test that has this type of specificity that I was just saying, this would generate 10 false positives in these 1,000. So it will identify 11 positives, one of which is sick and the others are false positive. That takes a big burden on the credibility. And I really liked a lot what Alena Wicks was saying. So we have to be very careful in how to communicate these data, because people just say, well, it's the number of infections is so much higher than what we really have thought before. And that's why the flu is not worse than the corona, because we don't have 5% mortality rate. We have 0.5% mortality rate, because using the wrong tests in the wrong context can basically crank up the number of infections that we see. And basically it's possible that we underestimate really the danger of that disease. And that has political impacts as well as ethical implications. So I just wanted to make that comment.
Oh, thanks a lot. And that takes us nicely also to maybe also, Professor Wicks, what is your take on ethical aspects? Yeah, I mean, I think we heard a lot about opportunities, about using data, about improving, about agility. There are obviously ethical aspects. Yeah, there are aspects in communicating, and also, I mean, the current regime that we have, the legal regime, data privacy, basis, use of data on individual consents. Do you think this is the right way, also on an ethical, from an ethical point of view, to enable that quality improvement that we need?
Well, thank you. Those are some very big questions. And I want to follow up from what Bert and Michael have said before. Let me just make a few different points and then say something as concrete as possible for an ethicist. So first of all, we've talked about the impact of AI, and I think what we need, once the fog is lifted, Bart, is that what you use, the expression? I love that, thank you. I think we will have to overhaul data legislation. I think that is quite clear. So let's table that for now, because that is quite an undertaking, and we've only just went through the GDPR efforts. So we know that it's not a small thing, but that is a recognized issue, in particular with machine learning and so-called AI based medical technologies getting towards the clinic. There is an imperative here to do that. The second thing I just want to say is I want to give a shout out to my colleagues in digital ethics who've produced some absolutely stellar work very quickly in the COVID pandemic on how we can fold ethical concerns in a pragmatic way into the development of digital tools for the pandemic. So I just want to direct your attention. There's a wonderful Nature paper by colleagues from Oxford, for example, which pretty much gives you a list of things to consider. And I think even for policymakers, these are very practical tools. So it's not something that is very complicated. And I want to very strongly support what Michael Neumeyer just said about the difficulty of communication of risks, which we've been dealing with in the digital ethics field, of course, for decades, if you will. And I think what this pandemic is showing us, that this was always sort of, so when I used to go to conferences on data-driven medicine, for example, the communication slot was always the last one. Ethics was one before communication, and then the last one was communication. Sometimes it was the other way around. And also in public health conferences, communication was sort of on the Saturday before lunch, right? When everybody was leaving because they wanted to have lunch at home. So these issues, and I'm not complaining, but I just want to say, I think the pandemic has shown us this is vitally important, because we can make the best legislation that we want. We can develop the best tools that we want. We can develop the best tests that we want. We can make the best sort of, as policymakers, legislate for the best measures against this pandemic. If people don't help and don't do it, it won't work, none of it. So it's extremely important. And I think that's what we've learned, that we need to be able and take it seriously that we communicate about these complexities. For example, the antigen tests. I think that's a very important point. When I take this test, I want to see my grandma in her assisted living facility. How safe is it? That's what people want to know. And it's not easy, so we have to take the trouble to communicate this responsibly and well. And that is difficult. And so I think we need to elevate these kinds of topics into our consciousness, all of us. So that's sort of my message, if you will, to everyone. And the final point, which is going to be a little more concrete, because Dagmar, you asked about what can we do in this with our data regimes, which, I mean, I'm German and we're famous, world famous for our, yeah, I see people laughing, right? You know what I'm talking about. Germans, we take our data protection very seriously, and we're famous for a certain, let me say, dysfunctionality there in this respect. But of course, it's not a laughing matter. We take it seriously because, as I said, data protection exhibits the confluence of various civil rights. They all come together behind sort of the data aspect: privacy, sovereignty, even ownership. And the problem is, in a crisis, we do impact on personal liberties all the time, but with other personal liberties, like where can I go, who can I meet, it's temporary. It affects my personal liberty at that time, and then it's over again. However, with data, the data has then moved, right? And it is somewhere, and people are worried. So we have to take that very seriously. And so I still think the gold standard, wherever possible, should of course be individual consent and control. But we also know that it cannot be possible all the time. And also we all know that in other areas of life, we've long said goodbye to individual control over data, right? I mean, people are very happy to use social media, and we have huge issues there. But of course, it also highlights that we shouldn't proceed the way social media companies proceed. But I think with a view to research, with a view to important other civil rights and liberties, such as protection of life by the state, for example, we can make that point. And so there are, I think, 3 ways to go about this. One is, of course, to try as much as we can with voluntary approaches, which we've done in Germany with our COVID warning app, which is completely voluntary. And now people are starting to say it might not be enough, but I think from an ethical point of view, that is, of course, a very good way. We could progress to dynamic consent models. There's a lot of work on these. Many people will know that there are ways where you can sort of delegate some of your consent and simply say, once I'm fine, do whatever you want, or there are different options. The second thing is, and that's more for, I don't know, I think it was Michael who said that about the epidemiological data collections. I think we, as researchers, and I say that to my researchers that I work with, we need to be bolder about using the research exemption in the GDPR. I think there is a great reluctance, and I understand that. Having sat on ethics committees and having done ethics advisory to European research consortia, I understand that people are reluctant to use that exemption because they've been drilled towards respecting individual consent so much. But there is this balancing of interests in the research exemption. And if there ever was a time where we can really say there are public interests at stake that might overrule the individual's right and interest to sort of keep full control over their data, then it's now. And there's it's a legal basis. I'm not a lawyer, so I'll leave it to you lawyers to hash out exactly how to do that. But I want to say to my research colleagues that we should be bolder to use that as the legal basis for research and not always individual consent. And the final and third point, and that again fits with looks more towards clinical applications. And a colleague of mine, Christiane Wopen, has made that point recently publicly. And we've, in the German Ethics Council, we've written a big, thick report on all of these data issues. And we've also made that point already there, that we should use the tool of data trusteeship more. Bert spoke about the commons idea, so there's a lot there, of course, but I want to, in particular, with a view to policy making around the clinical sphere, where it's not that much about how to get the data into a commons, but how to make sure that secondary data use can occur in a safe way. That's something that we need right now. We need to be able to have the health authority data as quickly as possible. We need to have the testing data. We need to know how to deal with the data from the hospitals so that we can do whatever we can to address this crisis. And data trustees could be a real option. They would be very compatible with current ideas of data sovereignty. They would correspond with most countries' legal basis, and they are usually they could be very highly trusted institutions. So in Germany, for example, it could be the Bundesdruckerei, which makes seals and money, if you will, sort of one of the safest. They build, of course, these days that's what they do. They build safe data infrastructures. And there are a bunch of other things that we could do in this area, thinking more about this trusteeship, because the main, and I'll stop in a minute, the main concern of individuals and peoples these days is, I don't trust you. I don't want to give you my data. And these days, it could also be that people say, I don't trust the state anymore. I don't want to give you my data. But they might trust a trustee, as the name sort of implies. They might say, okay, I can deal with that. If my data is not with the state, if I give my data now, and I don't have to be afraid that forever the state will know how I moved during the pandemic, right? Whether I kept my quarantine or didn't. These kinds of very, very sensitive informations that we are talking about. If a trustee has those and will destroy them later on, and only use what we need to help us deal with the pandemic, that could be a way forward. And so I want to leave you with these three sort of avenues where we don't have to overhaul the entire system, which I don't think we can do just like that, of course. We're working on that, but it will take time. But we might get somewhere in a pragmatic, quick way without compromising on ethical and legal considerations. Thank you very much.
Thank you. Yeah, Mr. Leiter, I think that is directly addressing the politics side of it, yeah, because I mean, you are one of the persons representing the lawmakers, and I think this is a call on maybe a bit more flexibility on the side of data to really facilitate that progress that seems to be technically possible, but of course, with the legal framework not as quickly achievable as otherwise. So what do you think?
Well, I think that all of what we've heard until now has shown the importance of data and how data is a prerequisite for the digital transformation or transition, if you will, in towards having a more efficient and effective health system, or even a health policy, to use a broader term in the face of actually what Francesca was mentioning, of dealing with all of the determinants of health, which is something that most of our health policy makers are not focused on as much as they should. The truth is, we need to evolve. If we want to evolve, as I said in my first intervention, from this disease system to a health system, we need to move away from just using digital technologies, as in most health systems, where they are used basically to store and organize and share information. It's not enough. And Bart was mentioning the importance of artificial intelligence and similar technologies. The truth is, without high-level quality data, artificial intelligence will never be more than just a dream.
Yeah.
Using it at a widespread, universal manner, being able to use artificial intelligence as a tool to make us better physicians, helping us as clinical decision support systems, but also helping us at the managerial side, helping us make better decisions in terms of management, even making sure that we are one step ahead, if you will, in terms of what needs to be done within the system. I do not need to explain to everyone in the room the importance of such tools in the face of an emergency or of a pandemic, and the absence of any kind of evolution in that sense from a governmental perspective has shown how we are slow many times to react, and we are caught a bit off guard. So we need that data so that we can use these other technologies. And only when we have that can we truly evolve towards having new financing models that can incentivize health managers and incentivize everyone within the system towards having better health outcomes. Today, this is not possible in most settings. We do not have the information that we need and the data that we need to be able to create those new financial models. So when we talk about value-based healthcare, for example, it's once again, it's really a dream of focusing on health outcomes, but most settings we're not measuring those outcomes and we're not standardizing those.
Sure.
And there's another question that Elena brought about that I think is extremely important, especially here in Europe with GDPR. Then the question is, if we acknowledge that data can save lives, that giving out data is the same as giving out blood, that we, the donation perspective of data can help us become healthier as a people. How do we get citizens on board? And I think we need to discuss this also from a digital perspective. What are the technologies do we have to give control to the people? We've been hearing about blockchain for so many years, but we're not seeing it being transitioned into the real world in most settings. With that kind of technology, then we could discuss about incentivizing the use of data or the sharing of data by citizens, for example, by monetizing that act of sharing. That is something that I think is a discussion we need to have, because if we want citizens to come on board, if we want to do this within the legal frameworks that exist, from a policy perspective, we need to use more of behavioral economics. We need to nudge people in the direction of participating actively, not because they're told to, but because they want to, because they understand it's for a greater good. And we are very far, I believe, from that point. But there are so many other advantages. If you think about clinical trials, for example, we are slow many times because we do not have the data when we want to identify the patients that are out there that fill in the prerequisites that a clinical trial needs. We are very slow at identifying them and then monitoring the results and being able to compare at an international level. At other levels, I was a deputy mayor of a mid-sized city here in Portugal called Cascais, 200,000 inhabitants, and we developed a tool called Smart Health, where basically we geo-reference all of the health, social, and educational data so we can see it on a map. And imagine that kind of technology being used to make very important decisions that have a health impact. I'll give you one example. Knowing the incidence of obesity and childhood obesity within a city, and you know the zip codes where you have greater problems, so you can actually redesign your bike lanes. Or for example, with a country like my own where we have electronic prescription, we can see where most antidepressant drugs and anxiety drugs are sold so that we can understand the underlying mental health issues. Without that kind of organization of data, it is impossible for policymakers to make decisions. This can apply also to what Francesca was saying about having that kind of reserve force of healthcare workers that can be identified, those that have been trained. In March, I delivered to the government a suggestion that we map immediately all of those physicians and nurses that have had any kind of intensive care training over the last 5 years so that over the summer we could prepare them. If this had been done, we could have a reserve army ready to step in, because building up a workforce ready to work in intensive care environment is not something you do from one day to the next. It's not just hiring doctors and nurses. You need to prepare, and digital technologies can help us be in the forefront of that response. And one last comment is also on decision-making, especially from a policy perspective. At my university, at the Catholic University here in Lisbon, we have been working a lot around gamification of policymaking. using mathematical modeling, and then creating tools that allow policymakers to change policies on an app on their phone, and then seeing the health outcomes of those decisions in years to come. We've applied this to viral hepatitis, to hepatitis C, and we're applying it in two other fields. So we're actually creating a safe environment for those that have to make decisions. And I can see this applied to the management settings. I can see this applied to climate change. These kind of tools, using good data and using technology, can make it, with a very user-friendly interface, a tool that can help all of those in the position of having to make decisions that impact on all of us, being able to forecast the impact, and as they make the decision, to then see if we're on track, to make sure that if we need to correct our trajectory, we can do so in a timely manner.
So I think what we heard, all of it, I mean, there is a lot of chances and progress. One aspect is, of course, Professor Dürrnagel, and that I think is also part of your research. It seems to be all interdisciplinary, right? I mean, topics like agility, like digitalization, and also I think this is really something that requests a lot of interdisciplinary interaction. And of course, there is a lot of opportunity, as we see, but maybe also some boundaries. Yeah, and since you're also more in the field of basic research, where the question of quality, maybe where things really need to take a long time, we have to differentiate, right? It's not everything can be achieved with speed alone. So maybe you have some thoughts on that.
Well, thank you. So I guess the good news again is that we have previous experience, good and bad experience of many things. So maybe I can just flesh out a few challenges and opportunities that I see in COVID research with a few examples. Right now, we see too many small trials. I think that's also something that we had before, but now it's getting grotesque, and too many trials on the same subjects. For example, there were hundreds of trials on chloroquine. So there needs to be some prioritization of the most relevant questions. And that's also because despite a pandemic scale, a competition about patients, to recruit patients into trials has become a major bottleneck for many studies. And then there's the need to homogenize study protocols. Deborah Sarin, the head of the clinical trial .gov website, she did a study on this, and she found a bewildering heterogeneity. I mean, just to give you one example, a large fraction of COVID trials use what they call a COVID ordinal scale, giving you the impression there is one, but there is none. I mean, it's their own COVID ordinal scale. And for example, some code death of a patient as 10, some as 8, and some as 1. How would you ever be able to synthesize the available evidence? So there is clear room for improvement. We also need to make sure that all these results are published, positive or negative. And we all know that even before COVID, we had a huge problem with delayed or non-publication of studies. And I'm really afraid that it might be the same or even worse with COVID now. And finally, and that's something that has not been touched upon, and I think we should not disregard this. There are other global health problems, which we should not forget or neglect because of the current emphasis on COVID. I mean, there's a COVID track during the World Health Summit now, but there is other stuff going on. I think malaria, Alzheimer, cancer, and so forth, TBC. And this is not only about prevention, diagnosis, and treatment, where we are, I think, already seeing a shift away to COVID, where then we have problems in these other diseases. And that's also true, I think, for research, where you can measure, there's meta research on it. We can show that there's a shift in publications from COVID, from other fields into the COVID field. And I think that's also something we need to not only monitor, but react upon. It's so I think, understandable in a way, and to a certain degree, maybe also necessary. But there's also a real danger about this. And this is also then about prioritizing what we are doing here.
Yeah, that's a very interesting point. And just one further question, Professor Dürrnagel, how do you think can this be achieved? I mean, how would you approach it if you say, well, it needs to be too many small priorities? Is it politics to address it, or is it the scientific community?
That's an obvious question. It's also a difficult one, but I think it's both. It's science meeting politics, and we see in I think a lot of what we see in politics is now that it's survival of the ideas that fit to politics. In politics, and also I think in science we have a lot of I think the word cacophonia came up. So I think we need a more evidence-based approach to many of the things that could be used for prioritization. It could be used for these saying which studies are needed and so forth. I think there have been health crises before where this has already been developed. I mean, there are ways of informing policymakers in an evidence-based fashion, and we don't see, to my analysis, I would say, I don't see this in many countries, if any. I mean, it's clear that this is not the case in the US, but even if you look at Germany, for example, where we have politicians that talk to scientists and even a physicist as a chancellor, most of the evidence seems to be eminence-based. We don't have a COVID national task force that really in an evidence-based fashion discusses these things. And this is true, I think, for most other countries. The UK has something like this, but it's completely non-transparent what they're doing. So if you ask me what we need to do, I think this is what we need to do. We should put the interaction of science and policy making on an evidence base. And this is hard enough, and we can do this. I think we can start now, but we need to have this ready for the next pandemic, which certainly will strike.
Thank you. So I think, I mean, this is a question also to politics, yeah, Mr. Leite, and maybe one further question that came from the audience, if it's the EU, yeah, if we look at it, how does politics ensure that there is sufficient focus, yeah, to direct the scientific efforts in the right manner? And where do you see it? Yeah, is it on a national level, on a state level, or even on the EU level?
Well, I think that this crisis has shown us that when it comes to emergency response, nobody was prepared. And despite all of the warning signs of past pandemic risks and threats, such as SARS or Ebola and others, we did not redesign our systems, both at the national and at the multilateral levels, to be prepared to respond. And so most governments were like Alice in Wonderland. When they don't know where they're going, any path will do. And that's the way we were evolving right now. And I feel that many are still a bit lost in the forest. So what needs to change moving forward? I would say when it comes to pandemic preparedness and response, first of all, I would like to underscore what Francesca said. We need to understand that our public health organizations are not prepared for this. And so we need more of a reserve, like a military-like approach, which means that we will probably have to have in each country emergency response, preparedness and response teams that have the training needed with the command and the control and command kind of approach, where they do constant simulations, airborne threats, waterborne threats, constantly ready, on guard, but constantly also monitoring what is happening to early detect any threats and to contain them. Let's be honest. If we had done our homework at the global level, we wouldn't be dealing with this pandemic right now. We should have been more efficient to identify and contain this threat before it became a pandemic, as we're dealing with it today. But having those national responses will not be enough. And this is a challenge because we are in a multilateral cross-border situation, but at the same time, we are seeing a rise of nationalism where everybody's just turning towards ourselves and to within. And even policymakers, myself, people think that we should be focused on the response in our towns and our cities instead of looking at the big picture. And the truth is, in future pandemic, which will end up happening because we do live in a globalized world, we need to have a multilateral response. And I think I really like calling on this idea of a NATO for health, for example, but instead of having it at a regional level, having it at a global level. What I mean by this is that if each country has its own preparedness and response teams, ready, prepared, constantly on guard, constantly simulating, then we could have some kind of body, which WHO could play a potential role in as a technical, scientific body, but it would need, of course, different types of resources. But having this kind of NATO for health where we could coordinate those efforts at the cross-border level. Without something like this, we can have the best responses at the national level, but we will always fail to respond in the face of global threats. And we need to make sure that we involve all of the different parties that can actually influence change in that discussion. I like to call on the Pentagram for change, which of course involves politicians, because at the end of the day, they make these decisions, or policymakers at large, if you will. But you need the scientific community. You need media to play a more active role, be it social or conventional media. You need the private sector. You need to bring them together. You need to bridge that gap between the social, the public, and the private sector. And we need to make sure that we involve civil society, NGOs, community-based organizations. Those that are at the fringes of society will never be reached. They will be left behind. They will be left out of our solutions if we do not include them. And having this kind of pentagram approach to the changes that are needed, I think we can be more effective. And for this, we need political leaders to be open to this, to understand that we are living in a time where all of these different knowledge sources need to be incorporated into the decision-making process.
Thank you very much. Professor Neumeyer, you want to add something to that?
Yeah, I would like to, particularly to the comments that Ricardo made. Certainly, it's fully agreeable. I think comparing the Corona crisis to the preceding crisis like SARS and MERS, I think the people have not made the right adaptations to prevent and foresee what would be happening in this type of pandemic for several reasons, I guess. And global traveling and all these things are certainly behind the spread around the world. And you can see this even if you look at the Spanish flu. You could argue that there was a global movement of soldiers in this case, also had this basically the same effect. But let's just say about how to control this. Control by just top down from the government and from the legislation is fine. We can see that this is effective, or has been effective also in the Corona crisis now. Let's say, for example, in Korea, or let's say in China, has not been effective in the US as an example from the other side of the spectrum. And it has to do, in my opinion, with the individualistic nature of our societies. You would need to add an additional aspect to this control of a pandemic altogether, which would be participation of the people. They need to understand what is going on, and they need to participate in this. And you were saying before that medicine has been slow on digitalization. It certainly is the case. If you look at all the other areas in society, like economy, things like Industry 4.0, and so these things have been done. Digitalization has been going on for many, many years in many areas of the society, but not in medicine. It has certain reasons behind the structure of our medical process. And this is now being addressed since 20 years, maybe, when we started to go through a P3 medicine, which is a personalized preventive and predictive medicine. But that has not worked either so far. And that, I always thought it was interesting, because we all know that if your cholesterol is too high, if you don't exercise, if you drink too much, and so on, this is all harmful and you can prevent it, and but people did not share in this whole process, and nothing has come out of it. Only now we see, in my opinion, we see a change, and this is governed by and driven by participation. So the people that have their Apple Watches or whatever type of monitors, and they start taking care of their own health on a non-evidence based, but on a personalized, individualized basis. So this probably makes a big difference, and we have to make clear that people understand what the importance of testing is, what the importance of getting the data right and interpreting data is in my opinion as much important as is the control from legislation, and also just restricting globalized spread, for example, by cutting down on travel and these types of things. So I think
we have, unfortunately, because I think this discussion is really fascinating, some limitations on time. And I see that Professor Büchs has also already raised her hand to remark something. Maybe one thing, maybe one last question that comes from the audience, and maybe we can direct that. Let's see who wants to volunteer on that. Maybe Professor Büchs or De Witte. It is also in terms of digitalization that the clinical part of health is something that needs its space, and how to balance digitalization with necessary non-digital needs. Is that something you think is also an important element, or do we think more at first, let's get into digitalization and then see how we balance it? I don't know what your take is on that question. Maybe Barty Witte first, and then I would give the last word to Professor Büchs, if that's fine for you.
Yeah, and thank you for asking the question. It's an important one, and it comes back to the main question that we need to ask: for which problem is the digitalization of medicine a solution? The example you gave or the audience gave, the question is a very important question, because it means what are we going to do with the free capacities that automation or digitalization lead to? I sometimes advocate that we need a billing position for empathy, because there are things that machines can't do as good as humans do. And if we go back to the origins of medicine, the human part, the humanistic part is a very important, that plays a crucial role in the care of an individual. So I think we all need to find a shared purpose why we are digitizing healthcare. And I think I always come back to that. I think we are not aligned of that purpose. For others, the purpose is to create $1 trillion industry. For the others, it's about using the technology to further democratize and destroy inequalities. And I think that's what we need to align on. During COVID, we have a shared enemy, which leads to a shared purpose, which aligns everybody in the same direction. After the smog has cleared, we need to really ask ourselves in which direction we are going to follow, because that's what creates community. It's the shared purpose, it's the shared values, it's the shared principles that will allow us to collaborate globally, open. And I hope, in my sake with my NGO, that it's all about destroying inequalities and using technology to further democratize access to healthcare.
Okay, then Professor Büchs.
That follows on very nicely, and I'll try to be very brief. I work on global solidarity, so this is an enormous challenge. And what I would like to say is that I think we need to be careful not to have the message, why didn't they all collaborate globally? There are very good reasons for that. We have national constitutions that countries have to adhere to, that demand in many cases that they have to prioritize their own populations. We have hugely different healthcare systems across the world. I'm not saying that's good, but we just have to be realistic. That is what it is. Not all the countries that, for example, collaborate with WHO are democracies. And we also have some democracies where leading politicians are very important sources of fake news. So we have had enormous challenges. So I think it's important not to get the message across. It was all a sort of a lack of will, and it just didn't happen because people, didn't think it was important or relevant or necessary. I think what we now need to do, and that's why it follows on so well from Bart, and I can say this in 2 sentences, is we need to look forward, and we need to use this crisis in its potential of having shown us that we're all interdependent, whether if we want it or not. We're in this boat together. We require global solidarity and global cooperation if we really want to get through this crisis, and in particularly, as Ulrich Dirnagel said, the next one. And so there is no question that we need a coordinating body. I think Ricardo mentioned that at WHO level. There is a preparedness group already, but I think countries need to really, really get into building these kinds of infrastructures more seriously, endow them with more resources, and think about the power structures here. But final point, and that's what Michael said, all the citizens across the world need to participate too. So you need to think hard who you vote for, you need to get involved. These kinds of questions shouldn't be all decided at the highest level and at the highest infrastructural level, but we all, as citizens, have to be willing to do our part and to become engaged in this. And I think that the participation point has been highlighted almost as much as the solidarity point by this crisis. And so I think these are 2 sort of positive messages to end the meeting on. Thank you.
So I think, unfortunately, really, we are at the end of time because it's big questions. Yeah, of course, they cannot be resolved in 1.5 hours panel, although I think we have had so many aspects that need to be considered that it was really a very, very worthwhile discussion, and thank you so much for it. We touched various points that you raised, and that I at least in a short summary want to bring again to our attention. Yeah, the need for agility in healthcare systems, the really high opportunities that we have with digitalization to get to better and more efficient healthcare. Also the need for a high quality of data. Yeah, the topic came up, standardization. It can only be used efficiently if there is a high quality in the data, and on the other hand, a trust how the data are used. Yeah, so individual interests and common interests have to be balanced. We have a need for smart investing in healthcare to cope with the demands that we have seen. I liked the point that healthcare systems are the last line of defense and not the first line of defense. That calls also for an action on politics to focus, prioritize, yeah, and see that the health systems don't get the entire burden of a difficult political situation. I think, and the term of focus, yeah, that also it's really has to be discussed between science and politics to focus in a crisis on the right measures and put the energy in the right direction and not spread it out to be diverted to too many topics. And I think in the end, what also is needed is the responsibility of the individual. And maybe that's also one of the points that is important, as we have seen in the crisis, because well, healthcare can do so much, but if not every single person helps also in this crisis not to be affected, to take the necessary personal precautions, I think we all see that systems, irrespective if it's the healthcare or the political systems, easily come to a limit. So, and with this, I want really to thank you for this panel and end it, and well, hope it brings us to a next step, and hopefully also this crisis ends and we can take healthcare to the next level. Thank you so much. Thank you.
Thank you all.
Thank you. Goodbye.
Goodbye.
Thank you.
Thank you. Bye-bye.